अस्सलाम वालेकुम, कैसे हैं आप लोग? ठीक हैं? प्रोफेसर डॉक्टर अबरार अपने लेक्चर्स के साथ आपके साथ हाज़िर है। आज मैं आपको अपने जो लेक्चर्स में से पहला लेक्चर कंटिन्यू करूँगा। वो लेक्चर है बेसिकली एंड्रोनिक कॉन्सेप्ट्स के बारे में। हम बहुत से एंड्रोनिक कॉन्सेप्ट ऐसे करते हैं जो कि अब आउटडेटेड हो गए हैं, ठीक है? और चूँकि टाइम गुज़रता जा रहा है वक़्त के साथ-साथ वो कॉन्सेप्ट जो है ना वो आउटडेटेड हो गए हैं। और उसमें से एक कॉन्सेप्ट पहले मैं डिस्कस करूँगा आपके साथ कि जब हम वर्किंग लेंथ लेते हैं और रेडियोग्राफ लेते हैं तो वी बेसिकली ट्रस्ट आवर रेडियोग्राफ्स। और रेडियोग्राफ पे फॉर एग्जांपल जैसे अगर आप इस रेडियोग्राफ पे देखें तो ऑब्वियसली आपको ये देखने में लग रहा है कि ये रेडियोग्राफ जो है वो उस पर जो फाइल है या जीबी पॉइंट्स है वो शॉर्ट लगा रहा है। बट अगर आप उसको एक्सट्रैक्ट करके देखें तो देखने में तो it seems to be very short, but actually we are on the right track because the radiograph what you see is that this portion is the radiographic tip or the anatomical apex. But we are supposed to do the obturation at the minor constriction or the apical constriction, which is might be 1 millimeter, 2 millimeter, or even higher. So always verify your radiograph with your apex locator. That's make it a rule. Always verify it. Apex locator verify should be done verify with your radiograph. Radiograph should be verified with your apex locator. Another concept, which is again an odd concept, is the Oling. If the patient is coming with the pain with the pulpitis, the irreversible pulpitis. So usually what we do in the OPD is we open the chamber. Only if you open the chamber with dental burrs actually promotes thermal injury to the already inflamed pulp. So ideally we are supposed to remove the whole pulp, do the pulpectomy, or at least remove the pulp from the largest canal or do the complete pulpotomy because the inflammation cannot be detected clinically. So it's better that you supposed to take out the pulp, complete pulp. Another concept which is again instead outdated concept is the initial finding concept. We always do that, do some initial filing. No, there is not such a concept of initial filing. What you do is to do a complete pulpectomy. If the patient is coming with an pulp inflamed and irreversible pulpitis, then you're supposed to remove the complete pulp. There is no initial filing concept, and which cannot guarantee you the complete removal of the pain. The complete removal of the pain is the complete removal of the pulp. So there's a concept, don't touch or don't leave. या छेड़ो नहीं या छोड़ो नहीं pulp को. It's just like that if there's inflammation here and you're putting these swords and burrs, if you compare these fire with these burrs, because these burrs cause the thermal injury to the already inflamed pulp, as they shattered the pulp. Similarly, these files work as swords. So if the pulp remain intact, the post-op pain may be increased. So it's better to take out the pulp completely. Otherwise, it's just like as that you are rubbing or salt on one's food. आप यार हम सबों पे नमक छिड़क रहे हैं उस पर, तो बेहतर ये है कि कंप्लीट पल्प निकाला जाए. Another is the concept is that using these medication, cristophene and pulpar. I'm not against with these medications. They have studies that they work in inflamed cases, pulpal inflammation cases, but it's better to remove the pulp completely. The best and safest and the best method to relieve the pain of the pulp inflammation is to remove the complete pulp. Okay, another concept is that tender tooth after obturation. You said initially the patient is suffering from infected apical periodontitis, but when you're doing a root canal treatment, the patient is now might be suffering from chemical apical periodontitis because the sealer might go out, might your file will soak with hypochlorite can go out. So it's better if you are doing a root canal treatment, the tooth might become tender. It's not because of the infection, it's because of the trauma if you're not doing out-of-occlusion, or it's because of the chemical periodontitis, which may be because of the intracranial medication or sealers. So this is one of the case. You can see this is a seepage of sealer outside the canal. Another concept, which is an outdated concept, is delaying permanent restoration for weeks after obturation in a symptomatic tooth. Coronal seal is equally important, as we know that. Uh, but it's better that you give a good coronal seal if you are doing a multiple visit root canal treatment or two visit root canal treatment. A carrot, if you're using it 4 to 5 millimeter for a week, or if you're giving GIC can give you provide a good seal for 1 month. If your root canal is adequate, then just put a crown, or if you have limited time, then you can put a crown with at least temporary cement, but give a good corner seal. That is really important. Giving a good corner seal is always important. Other concepts is antibiotic use. Use of antibiotic is basically if there's a cellulitis, cell-living angina, or if it's compromising airways, if there's massive swelling. Usually we give antibiotic in cases of the patients coming from irreversible pulpitis. The best method is to do root canal treatment. Don't give antibiotic just for the sake of giving antibiotic. So there are a typical indication giving, then you're supposed to give antibiotic in these cases. Another concept is the large cotton. You see there's a large cotton here and a very small cavity. Ideally, there should be a large cavity or very small cotton, or you might not use cotton. Cotton is not a good thing, and even if you want to use the cotton, you can use a sterile cotton. Another concept is the endodontic in a vital tender tooth. If the child, for example, 8 9 years old child is suffering from a subluxation or concussion injury, the tooth is suffering of a transient apical periodontitis, or you can call it sterile periodontitis or traumatic mechanical periodontitis. Tooth is vital. There is a tenderness, there is a loss of laminar dewar, there is a pedial thickening, there may be apical reducency and loss of sensitivity. You're supposed to wait, give soft diet, anti-inflammatory, and keep the tooth out of occlusion. No intervention required. See, there is the trauma, source of trauma here, the impact is here. So you're not supposed to take out the pulp. In young permanent tooth, for example, 8-year-old boy, if you take out the pulp, then the game is over. The odontoblast will be died because when you remove the pulp, and the tooth maturation will be completely stopped. So don't take out the pulp in these cases. Leaving the tooth open, if you're doing a surgery, will you leave this area open? You never leave this open. You always close it down. So it's always important when you leave the tooth open. Most of the time, this thing is going inside. Nothing is coming outside. It's very rare that you find the pus is coming out. And if the pus is coming out and you're not able to put the cavity or temporary aspiration, just fade it with the rubber dam on. And once the pus is stopped, just put the coronal restoration again. It's very important that put the coronal restoration again. Another concept is that temporary restoration with excessive time and limited depth. Whenever required, give a proper cavity diameter, like 4 to 5 millimeters, sorry, the depth for 1 week. And if the patient is going for, cannot, if you're not able to perform root canal single visit and the patient is going outside, you can give a slightly small cotton, and then we have this cavity, and then we have the overlay of GIC. So for example, if the patient is going for 1 month and you're not able to do single root canal, then you give a small cavity here, slightly cotton in the blue area, and then the big large GIC. And the patient come again, you open the tooth, remove the GIC, and then you find a softer area here, cavity, and you move it. Your canal will not be blocked and your corner seal will remain good. Always do out of occlusion. If the indication is the tooth is non-vital, there's a tooth tenderness, there's a pain initially, it's a mandatory tooth reduction. Kronfeld said the patient was initially suffering from apical periodontitis that was because of the infection. Now there is maybe a traumatic inflammation. So always do out of occlusion. It's important. Waiting for bone resorption to heal. This resorption takes months to develop and it requires months to heal. Even after root canal, don't wait for the obturation, for the coronal seal. Once you have done a good obturation, just give a good coronal seal and your good crown, and this minerals will come again itself. Don't wait that it if you wait for a few months With the temporary cement, it will never heal. Another concept is not giving an analgesic. There is a mechanism, local hyperalgesia. Hyperalgesia after endodontics is basically comprised of two things: hyperalgesia, which is located to the periphery, and what is central. The peripheral hyperalgesia is basically covered with your root canal treatment, but the central hyperalgesia, it will covered by your painkiller. Always give anti-inflammatory analgesics to the patient to break the pain cycles. Hyperalgesia is diagnosed by spontaneous pain, increased pain perception, and decreased pain threshold. Whatever kind of root canal you have done, if you're 100% sure of a root canal, even then give analgesics and anti-inflammatory to break the pain cycles. Don't use saline. You still people using saline and hyaluron peroxide. Saline is not a good. You said sometimes even the microorganisms survive in saline and even sometimes work as a culture media. Use hypochlorite or recently introduced different irrigation agents, but don't use saline. Saline is not a good irrigating agent at all. Another concept is people still using step back technique. There are so many reasons that you're supposed to use crown down technique. There's a better irrigant delivery, there's a better instrumentation, less pushing of debris, better access. So always use crown down techniques. They are far better as compared to step back techniques. Multiple visits versus single visit. All if you're going for open heart surgery, will you do multiple visits? Will you want to reopen it? You want to resuture it? There's a contaminated chances. There will be delayed wound healing. Always go for single visit root canal treatment unless and until the root canal is heavily infected or it's a retreatment cases and you want support you want to put intracanal medication. Do this procedure in single visit. You know the anatomy, you know the coronal seal, you know you don't have to put separate instruments again and again. They're less time consuming and research says it's less painful. Another concept is people don't have the 15 number file in the 10 number file in the clinic. They start using the 15 number file as an initial file. Don't use 15 number file as an initial file. Always use 10 number or smaller file as an initial file. And if you use 15 number file, it will block the canal and make subsequent root canal treatment is very difficult. This is few concepts I discussed. In upcoming lectures, I will discuss in details regarding these concepts and their what benefits we can have with the latest techniques. Okay, so subscribe my channel, hit the bell icon so you'll get the update with the new videos, and subscribe my channel. Thank you very much. Take care. Allah Hafiz.